Okay, great. Well, thank you so much for this opportunity. I think any time that able to talk with our wonderful patients, it's always a privilege and honor. Um, so, first, I just want, talk about, that cancer usually possesses several well-described hallmarks of how it develops, how it grows, invades, and spreads to other areas. And essentially at its core, the major challenge in treating any cancer is that cancer uses normal cell machinery to do bad things. And in theory, we have the ability to shut off, all or many of those mechanisms in cancer. The problem is that by doing such, we would also shut down those same mechanisms that are dependent upon normal cells. And that's where the major challenge lies, is creating something selective enough to where it's effective in 100% of the cancer cells and 0% of the normal cells. So, for this talk, I'm going to focus on the main tenet of immune oncology, which is immune escape. And essentially, normal cells through some cell surface receptors send out signals to notify the immune system that says, hey, we're normal, do not attack us. Unfortunately, cancer mimics those signals, often with a megaphone, to also tell the immune system to leave us alone because we're, quote, normal as well. And as such, they hide from an immune response. And unfortunately, because they're hidden, they're able to live, to grow, and metastasize. So we'll talk about a few examples of how to overcome this immune escape, but I think we all realize this interplay of immune response in cancer is very complex and moves rapidly by the day. There's multiple pathways or crosstalk, so this is not going to be an exhaustive talk, but really kind of hit some of the highlights. So I think first, wanted to point out, immuno-oncology is not new. In the late 1800s, Dr. William Colley reviewed multiple reports, 38 reports in literature, where patients had unintended fevers, whether it's post-operative infections, but had a fever of some sort, and noted that in those reports, there were better responses to their cancer. And there were 12 reported cures out of 38 patients. So, Dr. Colley created a remedy of toxins, which was really essentially a mixture of bacteria that he gave patients. And in 1908, reported a case series of treating over 400 cancer patients with 150 reported cures. As such, many folks consider Dr. Colley to be the grandfather of immuno-oncology. Now, obviously, a lot has changed since then, and we're not going to cover that gap of 100 years or so, but I did want to come back to, immune escape and how that plays a role in cancer. So at baseline, the immune system kind of cruises the body, keeping things in check. The immune cells float around looking for things that are not considered normal, such as bacteria, viruses, and even, cancer cells. T cells, one of the immune cells, roams the body looking for specific antigens, those receptors or signals on the outside of the cell to determine normal versus not normal. And so there are many of these different signals, but one in particular is PD-1. We'll talk a little bit about later, but when a T cell, recognizes and notices PD-1, they recognize it as normal, and the cell remains inactive, and they don't mount an immune response towards that cell because they see it as normal and part of us. Cancer, as I mentioned, mimics that and also has the ability to have PD-1 on their cell surface. So T cells cruise along, recognize this, and the cancer cell escapes that immune response because it tricks the immune cells into saying I'm normal when obviously cancer is not. So, it's been mentioned earlier today about immune checkpoint inhibitors. And that's a major class of immune therapy agents we have in our toolbox. And these inhibitors are specific to that signal. So, for example, PD-1 inhibitors competitively bind those receptors, which prevent a normal T cell binding, and thereby these T cells recognize those cells as not normal and become activated and attack and kill cancer cells, which is what we want. So, fast forward, here we are in 2018, and after 110 years after Dr. Colley described this toxins report, and Doctors Allison and Hanjo jointly won the Nobel Prize for Medicine with Dr. Hanjo describing the PD-1, as I mentioned, and its relationship with T cells, and Dr. Allison describing CTLA-4, which is another immunosuppressive molecule. And so the inhibition of these molecules with immune checkpoint inhibitors or immune blockade can successfully activate the immune system to help fight cancer. And this is obviously a monumental discovery, not only in immune oncology, but I think in just oncology treatments in and of itself. So, obviously the interaction of the immune system in cancer is significantly more complex than just the two checkpoints that I mentioned, CTLA-4 and PD-1. This slide represents other immune checkpoints that can possibly be other targets that we can look at. Each of which are involved in active research, looking for mechanisms of immune oncology and other targeted therapies that could hopefully gain, further insights and better, results. One easy snapshot that I like taking a look at, and when I'm looking at, at the field of medicine, how it's changing is looking at PubMed and their search criteria to look at these trends in research. And although cancer, immunology has been around for, well over 100 years, you can see the publications here have significantly increased over the past few years, and possibly even eclipsing 5,000 publications in 2021. So with more research, then accordingly, you have more number of agents, immune checkpoint inhibitors and the likes that are being created, and multiple indications by the FDA for immune oncology for many different cancers. And one of those indications, it was really for any tumor that has a high mutational burden. And we'll talk a little bit about that. And that includes ovarian cancer. But to date, there are no specific approvals for immuno-oncology agents in ovarian cancer specifically to date. And we aim to change that. So shifting gears a little bit, I want to talk about tumor mutational burden. So this is a nice sentinel study by Lawrence and his colleagues evaluating over 3,000 cancers with normal controls, looking for the amount of mutations within a cancer. And so for many reasons, the higher the mutations within a cancer typically lends to higher number of antigens, specific antigens on a patient cell, which by those new antigens that are there, those new signals, it allows easier recognition by the immune cells. And thus, the higher the mutations, the higher the number of antigens, the higher the response we could potentially see with immune therapy. So this red box represents ovarian cancer. There was nearly 400 cancers that were evaluated in this study. And although, as has been mentioned many times today, that ovarian cancer is genomically unstable, the genes are not stable, ovarian cancer is not considered a mutationally driven cancer. And so, whoops. So as you can see here, these highlighted areas represent current cancers that are mutationally driven, where immunotherapy could be of benefit. So green, green means go, and cancers that have mutations within this range typically do respond to immune therapy. The yellow has kind of an intermediate response, and red, honestly, an uncommon response, to immune therapy. And so, as you can see within the ovarian box, there are very few cancers that could potentially see a benefit from immune checkpoint inhibitor, specifically as a monotherapy. So we'll talk a little bit about these types, a few of these studies as examples. So this first study is Keynote 100. This utilized pembrolizumab, which is an immune checkpoint inhibitor, as a single agent in 235 patients with recurrent ovarian cancer. Unfortunately, the response rates were low, about 8%, which kind of fits with the previous, tumor mutational burden slides. And the progression-free survival, the time from the study agent start to progression of disease, was unfortunately low at just over 2 months. This is a table that kind of represents other clinical trials of single agent immune checkpoint inhibition. And just collectively, the response rates have been poor to date, with approximately 10% of patients responding to single agent or across multiple studies. So, what's the limitations? What is preventing us from having, higher response rates in ovarian cancer? It is multifold. I think despite the low response rates, we do see some patients who respond. The problem is we really lack reliable predictive biomarkers at this time to determine which patients those are. And additionally, the lack of kind of an overall tumor mutational burden portends a lack of specific antigens that tumors have, so that it's harder for the immune cells to really recognize ovarian cancer compared to other tumors that have a high mutational burden. So, given these limitations or gaps in knowledge, our current and future directions involve combinational therapy of immune checkpoint inhibitors plus chemo, or plus PARP inhibition, or plus, anti-angiogenic agents. And then, another thing we'll touch on here is, kind of alternative immune therapy strategies such as vaccine targeted therapies. So we'll touch on a few of these here. So, there's preclinical data, studies from the research lab demonstrating that chemotherapy can enrich or increase the number of immune cells that are within cancers. But to date, combinations of chemotherapy with immune checkpoint inhibitors has really yet to demonstrate a significant improvement. This one study, Javelin 200, is a trial in recurrent ovarian cancer with 3 arms, a single agent avelumab versus a single agent Doxil versus a third arm, which is a combination of both. And looking at the results, demonstrated similar progression-free survivals with Doxil alone at 3.5 months versus the combination of Doxil versus avelumab, which was just 3.7 months. So no extra benefit was seen in this study, and because of that, it was closed early to enrollment. It was considered futile. Another combination therapy, as mentioned, immune checkpoint plus PARP inhibition. There's also a rationale, in the lab with that PARP inhibition can actually induce an upregulation of PD-1 in tumor cells. So more of the PD-1 that's there. So a checkpoint inhibitor to counteract that could make it more susceptible to immune checkpoint inhibition. And in this Tapatio trial, which is a phase 2 trial of niraparib plus pembrolizumab, did demonstrate an improvement over that kind of 10% threshold that we typically see with monotherapy of 18% response rate in a heavily pretreated, platinum-resistant patients with ovarian cancer. A third study that I'd like to highlight, the Modalia Trial, is a combination trial that essentially tried to determine if more truly is more. There was a double regimen, which is the graph to the right, that was durvalumab, which is, again, another immune checkpoint inhibitor, plus olaparib, a PARP inhibitor. And that had another bump or improvement in response rate of 31%. And then to the left, you can see a triple regimen of durvalumab plus olaparib plus bevacizumab or Avastin. And that response rate was quite robust at 77%. Now, with a lot of these studies, there are small numbers of patients in each and need to be validated with further studies. But I definitely think it demonstrates that combinational therapies can make significant improvements over our limitations that we mentioned with a single agent immune therapy. So I also mentioned earlier about, vaccines. And vaccines that specifically target ovarian cancer. And I've been fortunate to represent a lot of my colleagues on a couple of studies looking at a genetically modified vaccine called Gemogenovatusal. Please don't make me say that twice. So we'll call it GEM from this point moving forward. And this first study is really a maintenance study of GEM vaccine in patients who have newly diagnosed ovarian cancer, advanced stage, that undergo their primary therapy of surgery and combinational chemo. And then once they received a good response to that first line therapy, patients were then randomized between GEM vaccine, versus placebo. And that's what this study entails. So, first, I just want to talk about the role of GEM. And as I frequently tell patients, if you line up 100 women in a room, all with ovarian cancer, each cancer is unique in regards to the tumor-specific antigens that are on their cancer cells. And so I mentioned these antigens, and the most commonly known are those on our red blood cells. The blood types. Type A, you have A receptors. Type B, you have B receptors. Type O, you don't have either one. And so, we target this in this vaccine. So I consider this vaccine a three-legged stool. Without any of these arms, the stool's not going to, or any of these legs, the stool's not going to work. So on the right-hand side, the first leg of that stool is that we target that individual patient's tumor-specific antigens from tumor that we remove at the time of surgery. And so it helps, with the vaccine attacking, those tumor antigens that are specific for each patient. The second leg is an immune booster to enhance the immune response, to that region. So I consider it like hitting the gas pedal and flooring the pedal in a car for the immune system, and that it helps recruit as many immune cells to the area as possible. And then the third leg is, cancer has normal suppressive, factors that try to defend themselves against attack by immune system. And so the third leg in the same kind of car analogy is that we cut the brakes. And so we cut the brakes to this car so that it can't stop the immune system. This car, can't slow down, won't slow down. And we think that combination of being targeted to the cancer cells, have an immune booster attached to this vaccine, and cutting the brakes to anything that's going to try to stop the immune system has been, effective. And so, the process here on the left of the pictures, at the time of surgery, we do a cytoreductive surgery for ovarian cancer. We take part of that cancer and send it to our colleagues in the lab and use and look for tumor-specific antigens that are quite unique to each patient. So in essence, Mrs. Jones' vaccine only works for Mrs. Jones. Mrs. Johnson, who also has ovarian cancer, she needs a separate vaccine created from her own tumor. And so technologies like this, in my opinion, is as targeted therapy can get. Then after, targeting to those tumor-specific antigens, it is genetically modified to, hit the gas, to have an immune boost, and then cut the brakes so it prevents the immune system from slowing down. So after that vaccine is created, again, these patients in this trial received all their upfront chemotherapy and surgery, and then they got up to 12, subcutaneous injections, depending on the amount of vaccine that was created, and then monitored those patients, over time. So before we talk about the results on that, I just wanted to hit on one important subject. It's already been mentioned about BRCA mutations and BRCA-like gene mutations. And those on the right-hand side of this pie chart are those homologous recombination deficient tumors. And so with that deficiency, the cells can't repair any damage that's there. And because they can't repair damage, that's why patients with these mutations tend to get more likely to get cancer. But those patients who do get cancer have always been more likely to respond to chemo, because chemotherapy causes damage to those cancer cells. And because they can't repair them, those cancer cells are more likely to respond and die to chemo. So just innately, with chemotherapy, we've had a survival disadvantage between patients with, homologous recombination deficient versus those with, homologous recombination proficient, where they could repair those cells. Now, that disparity between those survivals is actually worsened with PARP inhibition because, PARP typically works better in those patients who have homologous recombination deficiency. So I say all this because essentially homologous recombination proficient tumors have been a disparity, and that as this vaccine it specifically works better in those patients with homologous recombination proficient. So it's really, I think, fulfilling an unmet need in ovarian cancer that we hope provides better outcomes for those patients that have tumors that are proficient. So, now to the study, looking at the homologous recombination proficient patients. You can see, on the left-hand side, the recurrent-free interval was significantly improved from 5.7 to 10.6 months, and that overall survival was significantly improved from 27 months to median not reached. Looking at updated survival data from this cohort from up until April 20 of 21, you can see that it's encouraging that that survival advantage was still maintained. The 2-year survival advantage towards GEM was 92% versus 55%. And then 3-year overall survival was improved from 40% from placebo up to 70%. So it is nice to see that that survival has been maintained for up to 3 years. And obviously, we're going to follow these patients further. So one other quick trial I want to point out with GEM is a phase 1 study looking at GEM plus atezolizumab, which is another immune checkpoint inhibitor. And this is in a heavily pretreated ovarian cancer cohort of patients, looking at this combination to see if we can make any improvements, with this vaccine. So just, briefly, this study had patients randomized to 2 groups. Group A was 2 cycles of the GEM vaccine, followed by GEM plus atezo. Group B was 2 cycles up front of atezo alone, followed by GEM atezo. Both were treated until progression of disease. And the rationale of doing that kind of preload with either GEM or atezo was just to see if it was possible to kind of, quote, prime the immune system to better recognize the cancer cells. So the thought was that with GEM, we're getting a more targeted approach, where these vaccines are attacking that, cancer cells, and thereby, instead of a global immune response with just single agent, immune checkpoint inhibitors, are we better directing the immune system to the problem areas where the cancer actually lies? And that's the thought and rationale. So, what we found, I think, was encouraging, that the GEM first group, although they had more total side effects, the overwhelming majority of those side effects, nearly 98%, were very mild, grade 1 and grade 2. And if you look at serious side effects, there was a significant reduction from almost 17% severe adverse events in the atezo first arm to 2.4% in the GEM first arm. And so that really kind of supports that theory that if we prime the system, we get less off-target effects, and less, side effects of the immune system. Fortunately, it also appeared that priming a system with GEM first also improves survival compared to the atezo first. And as seen in other studies, the without BRCA gene mutation had better results, which is represented on the Kaplan-Meier survival curve on the right. So, obviously these studies, with the GEM vaccine are small. They need confirmation, but I think they're encouraging to the types of targeted therapies that we can do to hopefully overcome some of those limitations of immunotherapy in ovarian cancer. So just in summary, without question, immunotherapy in ovarian cancer, has its challenges, but we've seen significant improvements over the past 4 to 5 years with combinational therapies, targeted vaccine therapy that I highlighted a couple of studies. And I didn't dive into this, but hopefully, we're finding better biomarkers to really predict, those patients that would have the most robust response to immune therapy with ovarian cancer. And, I think we've come a long way, since the Kali toxins over, 110 years ago, but I'm very confident with the data and research that's being done that we're really close to some major breakthroughs. I think it's very exciting to look at this, and, our goals, like have been mentioned today, is, it's not here just to only improve survivals, but we really want to overcome, hence the name, and eradicate ovarian cancer. So I appreciate the opportunity to be with you guys or Zoom with you guys today. Thank you so much.